Dear President and Chairman, I'm Dr. Liu Weidong from China. But at first, I would like to thank the President of SDG, Dr. Clarori Armento, and the Secretary, Dr. Carlos Cuto, and everyone of the leading body of SDG. And many thanks also for the Dr. Ricardo Corporan and his son, Dr. Julian Ricardo Corporan, for meeting us in the airport and give our help, because it is my first time to this beautiful country. So thank all of you. I'm very happy to discuss it and give my appreciation with all of us. Thank you. My hospital, Xi'an Hospital of Central South University, located in the south of China. I think maybe some of us watch the famous movie, Avatar. Avatar was photographed in Zhangjiajie mountain. The mountain located in my province is very close to my hospital. And my hospital, Xi'an Hospital, was founded in 1906. It has, to this year, it has more than 120 years old. This is a very old building in our hospital. And now, our hospital has more than 3,500 beds. Now is the medical center of our country. I'm a surgeon for the colorectal surgery. And in the GI department, we have about 150 beds. And today, my topic is the surgical decision for the large pólipos. As the use of the laparoscopy, especially the widespread impression of the colorectal cancer screen, the incidence of colorectal polyp is growing higher and higher. Maybe the small polyp is very easy to treat it, but sometimes the large colorectal polyps, maybe it means about 20 millimeters. It's not easy to decide how to treat these large polyps. As we know, the main method for resection of the colorectal polyps, we can use the endoscopic resection, EMR or ESD, or transanal local excision, and TME by the surgeon. EMR is preferred for the large, but usually is the simple polyps. EMR can balance the safety with efficiency. And ESD can remove the difficult or very large polyps. It can remove the polyp in block. Sometimes, if the polyp is not easy to remove, we can do it by the surgeon, TAE, TAMIS, and TME. On the transanal excision, maybe the TAE, it can remove the rectal polypos, maybe less than 4 centimeters from the anal wall is okay. Also, we can use the transanal endoscopic microsurgery. And the distance between the tube and the anal wall is about from the 4 to 18 or 15 centimeters is okay. Also, today's TAMIS is also popular in China. Means the transanal minimal invasive surgery. We can remove the polypos between the 8 to 15 centimeters from the anal wall. But to do the TAMIS, I think we use the experience technique. But we always meet this clinical dilemma, especially when we face the oncological risk. Short large rectal polyp can be removed with the TME. So first, I want to discuss the necessity of TME for large rectal polyps. And first, I want to discuss 2 cases. The first case is the 72-year-old male. The colonoscopy found the rectal polyp 5 centimeters from the anal wall. And the pathology of the ESD reported venous tubular adenoma. Also have the focus of mucosa modulated purely differentiated adenocarcinoma, but the removal margin was negative. And the patient chose the watchful waiting. This male did not want to do this laparoscopy surgery. And maybe 9 months later, the colonoscopy found the tumor recurrent. And the pathology reported polydifferential adenocarcinoma. And MR showed this thickening of distal rectum. So we do the laparoscopy on laparoscopy TME. And the pathology reported T2 N2B M0. For these cases, we can see the first treatment strategy is under treatment. If we do the laparoscopy TME only, the result might be better. And the second case is a female 60 years old female. The first colonoscopy reported rectal polyp with the diameter is about 2 centimeters from the anal wall. And the biopsy reported the venous tubular adenoma with local modulated typia. The next year, the polyp recurred. And the pathology report is a similar result with the first endoscopy. But 7 years later, and between these 7 years, the patient has performed the just local resection for the polyp, and the patient did not want to do the APR. So 7 years later, the tumor recurred, and this is advanced rectal cancer. On MRI, confirmed the rectal vaginal fistula with enlarged lymph node in bilateral, intra-iliac, and obturator regions. This is a possible metastasis. So, in this time, we have no chance to do the surgery. So these two cases tell us we always meet with the challenge of a large polyp. So I call this the clinical dilemma. When we meet this large polypus patient, do we know how to make the decision for TME? I think the challenge have we must discuss the size, the oncology biopsy. Especially of the pathology report about the positive margin of high-risk T1 cancer, especially the poor differentiation on tumor burden, high tumor burden. Sometimes, if the T2 or deep cancer is easy to make the decision, we should to do the TME. Also, I want to discuss the minimal invasive advantage of TME. Because today, the laparoscopy or robot surgery is popular in the world, also in my country. TME has the strategic advantages. First, we can have the definitive radical cure. The second, it can eliminate the need for repeated endoscopic surveillance and multiple biopsy of resisted binocular excision, particularly in case with the indeterminate pathology and equal margins. And third, it can alleviate the considerable psychological distress, especially when the patient selects the watch and wait strategy. Because now we have the high quality laparoscopic system or robot system, we can see the very small novel system. We can preserve the function of the laparoscopic system, especially the sexual dysfunction and urinary incontinence of the surgery. When we do in the open surgery area, It's very difficult to preserve the pelvic autonomic nerves. But now, because we have the high quality system, we can do it. Even if the tumor is very low, maybe in the open times, we have to do the APR surgery or the removed patient anal. But now, because the high quality laparoscopy or robot system, we can preserve the rectal anal complex system, even if the tumor is very low. Of course, because the large polyp is a benign polypus or an early stage cancer, it's very important and maybe sometimes it's easy for us to preserve the to do the surgery with negative resection margin. Also, we always can do the transanal surgery by ISR to preserve the anus. Also, with the development of the surgery technique, we can do the end-to-side anastomosis or other new anastomotic technique. It can help us to preserve the anus. Even if the extremely low rectal polyp, this method not only mitigate leakage risk, but also it can contribute to improve the preservation of post-operative bowel function. But we also have the challenges for the TME. Of the TME surgery, the main challenge is the low anterior resection syndrome. In fact, it always occurs in 60% to 80%. Is very high, and the patient life quality is very low at these times. Another very difficult or important complication is the anastomotic leakage risk. Anastomotic leakage can lead to the chronic pelvic sepsis, structure, and poor function outcomes. In fact, many GI surgeons like to do the temporary ileostomy or colonostomy of the very low rectal cancer surgery. But the reality of stoma is that the stoma course often takes about more than 18 months, and about 20% of the ileostomy cannot close. It means, especially if the patient with the polyp is not cancer, it will influence his life quickly. In our hospital, we analyze the data for the past from 2008 to 2018, about 10 years data. The temporal ileostomy cannot close is about 18% is very high. Of course, if we do the APR, it will also affect the patient's psychologically. Also, when we do the laparoscopic surgery, it also includes patient burden, includes the clinic burden or the economic burden. So it is also very difficult for the patient to choose how to do it. So we always try best to do the polyp removal by this decision algorithm. If the patient with the large rectal polyp, it means the diameter is more than 2 centimeters. We always divide the patient into the high to moderate risk or low to moderate risk by the endoscopic morphology, size, and biopsy. If the patient with a diameter more than 4 centimeters polyp, I think CT-MRI is necessary to scan. We always try to decrease the surgery rate and try to remove the polyp by ESR and maybe local dissection. Sometimes I think watch and wait strategy is also less okay for the after local dissection is okay for the patient. Okay, thank you.